Good morning, everybody, and welcome to Global Neurosciences Institute Grand Round Series. And today, the introduction of our speaker, Dr. Michel Lacroix, will be a little bit different than usual, as my colleague, Dr. Adam Sarver, will be introducing him. Dr. Sarver.
Thanks, Peter. Thank you so much. Let me just share my screen, make sure you guys can see it. It's a real thrill for me to introduce Michel Lacroix. Michel has been a friend for over 10 years, and I first met him when I joined his practice at Geisinger Medical Center, which is just about 2.5 hours north and west of us in Philadelphia. Now, I say that I met Michel 10 years ago, but actually many of us in neurosurgery have met him over 20 years ago with this seminal paper that he had when he was at the MD Anderson Cancer Center, which was about the multivariate analysis of a really large number of glioma patients and linking resection and extent of resection to survival. And this was a really important paper, and this is something that I think brought Michel onto the national scene and recognition for his passion and excellence in research. Michel is currently the chair of the Geisinger Medical Neurosurgery Program in the Geisinger Neuroscience Institute. And it's hard for me to explain to you that it was such a small program when I joined it, and now it's a program that has a catchment area of 3 million people. He's got a host of neurosurgeons. He has a neurosurgical residency, and it's really a different program from when I started, and it's so impressive. Now, Michel's lineage, and you'll hear it when he starts giving his presentation, is from Quebec. He went to Laval University and was at McGill University as part of his medical training. And then, as you see, this sign that says Dr. Penfield, all of us in neurosurgery know that Wilder Penfield solved hard problems in neurosurgery. And the hard problem that Michel was put on was neuro-oncology. Additionally, Michel did training at MD Anderson, as I've mentioned, and now he's at Geisinger Medical Center. Two of his passions outside of work include his wife, Pam, and their 3 lovely children, Nick, Julien, and Luke. But when Michel's not researching and doing things with regards to neurosurgical techniques, or when he's not with the family, I can tell you that if there's a party to be had, Michel will find it. And then another passion for his, every June for I think the last over 30 years, Michel has been at the circuit at Gilles Villeneuve in Montreal, watching F1. Another passion that Michel has is wine, and certainly if there's wine to be had, Michel will come with a glass in hand, but always offering generous conviviality. So Michel, this morning, we'll ask you to fill our intellectual cups with information about laser interstitial therapy. And without much further ado, I give you mon ami, Michel Lacroix.
Oh, thank you so much, Adam, for this very kind invitation and kind words. I mean, our friendship has been it's been going on for a long time. So I'm delighted that Peter, you and Errol have invited me to share some of our experience today with laser interstitial therapy. So let me just put that here, and everybody sees my screen right now. Yes?
Yes, we can see it.
Very good. So I have no disclosure. I was delighted by the invitation because over the last 5 years, we've experimented with laser interstitial therapy for a different indication. And I'm going to share that part of the domain about surgical neuro-oncology. So today, I want to discuss a bit about the frontiers in glioma surgery, go into the concept and the procedural aspect of laser interstitial thermal therapy, look at 3 key indications, which are brain metastasis, glioma, and radiation necrosis, discuss through literature what is the state of the art today and where we're expecting advances in the very near future, and finishing with words of caution and at the same time entertaining any question you might have. So what our mission is on primary brain neoplasia, essentially at the beginning. So as we all know, the incidence of brain tumor is rather significant and appears to be increasing. It represents 1.4% of all cancer and 2.4% of all cancer death, 21% of childhood cancer, and 60% are malignant glioma. So it's extremely important to establish a diagnosis, as we all know, because they influence significantly the expected survival of these patients. And as we can see here on that plot, Kaplan-Meier, all of these different grades have a huge impact on the survival of these patients. So nowadays, with the new World Health Organization classification of tumor, we're going to open a door to more personalized medicine. But notwithstanding, I think surgery is going to have still a very critical role, and as always add, as Atom was mentioning, some of our effort was to demonstrate that clearly. But essentially, when we look at surgery for glioma, we think about providing a diagnosis as clear as possible, relieving symptomatic mass effect, priming postoperative therapy, chemo, radiation therapy, and alternative modality, prolonging survival. And that was the core essence of the paper that we were talking about in 2001, and decreasing the probability of further mutation towards resistant and applying locally delivered therapy. So the tumor that you see on the right side, I hope that everybody sees my arrow, is extremely complex. You see it encompass on the dominant side a large portion of the parietal lobe and all of the mesial temporal structure. You can see that on the sagittal image as well as in the axial image. On a patient on whom would be unthinkable at a certain time to do resection now, with MRI, new techniques, with brain navigation system, ultrasound, neurophysiological monitoring, and microsurgical technique, we can achieve resection that were once unthinkable in a patient that then leaves the hospital shortly after and has no further deficit than the one that he had originally, which was a field cut. So the essential part of that work was to demonstrate whether or not we could decrease or improve survival. And that was what was demonstrated by that paper on 416 patients. And you see those two Kaplan-Meier curves, nicely delineated patient that had more than 98% of resection or less. And that was pretty much an all or none at that point. We need to remove all of that tumor. And then a group at under Mitch Berger at UCSF redemonstrated that 10 years after, showing essentially that the cutoff was not all or none. The cutoff was more 75% of resection. And the most significant part was more than 90%. And as you can see again on these Kaplan-Meier, the interval survival is better the higher you get in terms of resection. That was on a group of 500 new glioblastoma patients. Then Nick Marco, who joined us after he wrote that paper in collaboration with the Cleveland Clinic and MD Anderson, that was in 2016, was plotting 750 patients to allow us to determine which one of these patients we had the most influence on. And when I say plotting, for a patient that is 40 years old with a KPS of 100 now, in comparison with a patient that is 84 and a KPS of 60, as you can see here, if you achieve 75% resection to 95% section, you have a delta of 135 days of better survival. For that patient, where you do again 75 to 95%, it's only 55 days. The patient is 84 years old with a KPS of 60. And then if you combine this with all other treatment modality in that plot, you can see that extent of resection plus combination of temozolomide, radiation therapy, or neither will give you the best survival. And that delta is 200 days for that 40 years old and is 90 days only for that 84 years old. Now, we understand that we need to remove as much as we can of these tumor, it's clear, but we have to use that with caution. When I'm looking at that seminal paper of McGirt that he wrote while he was at Mayo Clinic, you can see that all of the benefit that you have of resection, if it is associated with a surgical complication, you go down to basically a median survival that is worse than those patients would probably have if they didn't have an induced deficit. And you see, like, if you have a new perioperative motor deficit, the median survival is only 9 months, with only 8% of survival at 2 years. If you have a new perioperative language deficit, it's a median survival of 9.6 months, with no patient surviving after 2 years. So that tells us that we need to resect. There's a benefit to it, but we need to do that very safe. And all of us that are in the practice of oncology will recognize a patient similar to this one. So she is 58 years old. She comes to us because it's an incidental finding. We do a biopsy. It's a glioblastoma. And then shortly after, she starts her chemo and radiation therapy treatment. Unfortunately, she has blood dyscrasia while on chemotherapy, and so temozolomide has to be interrupted. And now she's coming to us. She's hemiplegic, she's aphasic, and she's failing to thrive. She's an avid gardener, so at that time, we had the laser option. So that lesion, for those that are familiar with this, is in a excruciatingly dangerous corridor, a no man's land, basically. So how can I access that lesion safely and then try to either remove or ablate some of it to hope having the same benefit as I demonstrated with resection on that individual? And the procedure was so successful that she went on to survive 2 years after the procedure, resolve most of her hemiplegia, and also improved and was fluently speaking, was even interviewed in a local channel after the procedure. So the fundamental of laser therapy, and this is what I'm going to go through now, is essentially a bit of that physical equation. So delta Q is the heat amount of energy that you acquire or you lost. The delta T is the temperature variation during that time. M is the mass of that tissue, and C is the tissue-specific heat capacity. So in a nutshell, if you're trying to boil your pasta, it's different than if you're trying to melt metal. And how can you apply that heat through a laser that can generate that heat in a very specific territory? And we know that since the 80s, now to heat tissue in the brain. So sorry about that. Now, that's the equation, and I will simplify that, so I don't want anybody to get too disturbed by this, but essentially, the extent of the thermal damage that you provoke to a tissue depends on the tissue sensitivity, the temperature, and the exposure time. So the thermal dose is represented as an exposure time at a reference temperature, which is 43 degrees centigrade, arbitrarily chosen. R is the temperature dependence of the rate of cell death. And essentially, this algorithm is used in performing a calculation in an MRI, which is an MRI thermometry for every pixel and at every time point during ablation. So extensive calibration has been involved in that to represent 100% kill, which is the TDT, or the thermal damage threshold. And this is represented as a contour line that I'm going to illustrate in a moment, where the depth of cell is blue and the affected area is yellow. So what is laser interstitial thermal therapy? It's an MRI-guided, minimally invasive procedure by which a laser catheter is inserted into a brain lesion, aiming at local heating and tissue denaturation. So basically, we put a bolt that you can see here on the head in the operating room that is in the ideal trajectory to host the laser that's going to be connected to that bolt while we are in the MRI suite. So we had the chance in 2019 to have this publication that was illustrating some of the damage that is inflicted to the tissue by laser therapy. Essentially, that patient underwent a laser interstitial thermal therapy, and a month later had to have a resection and block of his lesion because of persisting headache. And we define 3 zones. So there's a zone of pure necrosis that we can see here, but also a zone of inflammation where you can see macrophage, and you can see also granulation tissue. And there's still a zone of active brain tumor, as you can see here with the different staining. So those 3 zones are what we're expected, and we'll see what it looks like once we proceed. So essentially, the time dependence is critical. So if you're at more than 100 degrees, you vaporize the intracellular and extracellular wall and you rupture the cell membrane. If you're less than 43 degrees centigrade, there's no thermal damage and it's time independent. You can stay there forever. It's not going to change anything. So then between 44 and 100, you have these episodes where it's critical to understand what's happening in the brain. So at 44 to 59, you're going to have denaturation of critical enzyme and cell death, and that is time dependent. And from 60 to 100, it's denaturation of cell membrane, and it's instantaneous. So the sweet spot is definitely from 44 to 59. So essentially, MRI thermometry is what has enabled technology that existed for a long time to be applied blindly to the brain. So we're continuously monitoring the ablation in real time based on accurate temperature mapping of the region of interest. And this is accomplished through MR thermometry, which use a gradient recall echo or the GRE sequence that leverage 6 temperature-sensitive MRI parameter. And the resulting temperature measurement feeds into a thermal damage threshold, the TDT, which utilize temperature and time in a nonlinear manner to quantify the damage. So ultimately, this allowed the operator, so the surgeon, to determine when the tumor has been sufficiently ablated without injuring the surrounding normal brain. So when we look at this here, that's the technique itself. So the bolt has been implanted in the head. The patient now is in the gantry of the MRI. We've coupled that with a robotic arm that goes linearly inside of the tumor. This is why it's critical after we do our biopsy. We confirm the pathology. We know that there are tumors to be ablated. We have to have this perfect access within the tumor. So then the laser probe is introduced into the brain, and this is how it happens. So essentially, now we're fully compromised in that trajectory. We've done that trajectory in the longest axis of that tumor. And then with the neuroblade specifically, we are directional, and that directionality has helped me a lot when the tissue is surrounded by either cerebrospinal fluid or large vessel, and there's resistance to the ablation, so we can reorient and recannulate this, but always locked into the trajectory that we determined at the beginning, at the moment that we did the biopsy. It's going to illustrate that very well here. We have what is the console looking like of treatment. So you can see the same color palette of thermal happening with all of these pixels within the zone that we're interested in that are going to monitor temperature. So I can essentially displace that target here anywhere to follow accurately every 8 seconds what's happening in that brain tissue. And this is what guarantees me that I'm not going to go into the territory that would be uncharted and harmful for that patient. So on that one example, we have a 64-year-old woman that came with a new onset of left hemiparesia. Again, any one of us will recognize that this is a very perilous lesion to access by any means. And we don't know what that tumor is. So there's a need for a biopsy, and at the same time now a need for treatment, because no matter what, it's going to be very difficult if that tumor is not radiosensitive to do anything about this, but resection is not going to be feasible. There's no easy corridor of access. So what happened is that when we start, and of course this is accelerated, but you start seeing that yellow territory and that blue territory that I monitor constantly to see what kind of heat I generate in that lesion. So in the centerpiece here, I'm at the level of the laser, 5 millimeters deeper on the right side, 5 millimeters shallower on the left side. And during the procedure, I'm going to change the depth of what I'm doing and retracting through this robotic arm that lesion. And as you can see here, the depth of these cells and the depth or the zone that has been slightly impaired or injured is exactly that. The advantage also of being in the MRI suite is that I can have an immediate post-op MRI whereby I can determine if there was or not an injury associated with the procedure itself. And the vast majority of all of the patients that we've done over the last 5 years that were coming from home are going home the same day. So that's what the MRI looks after the procedure. So that's pre-op here, that's 2 months after, that very thin shell here with a little bit of inflammation response. You see that the content on the MRI, or the visualization on the MRI, is now profoundly changed to that thin egg gel. This is what we're hoping for. And then you can see at 6 months, there's still a little bit of inflammation, and then at 10 months, and then at 16 months, where there's none of that tumor appearance left. So the fundamental indication that I've been wrapping myself around are the following. So primary brain tumor, recurrent metastasis, radiation necrosis. And we'll go through the state of the art for each one of them. The ideal target is less than 3 centimeters. Jane Barnett was a strong advocate of multi-approach, so multiple introduction entry. I think that personally, the return on investment for lesions that are larger than 3 centimeters is not as strong as for a smaller lesion. And they have to be, of course, accessible through a safe corridor. But then you become very creative with these safe corridor. That's an example of a young woman in her 20s with 30 gelastic seizure a day that is presenting with a giant hypothalamic hamartoma. And as you can see here, I mean, that lesion is in a very daring environment. The optic radiation, the optic nerve, the chiasm, the large vessel, the middle cerebral peduncle, all of them are in very close proximity with CSF surrounding all of the structure. But she has 30 of these gelastic seizures. And again, I mean, to illustrate that even better, and as you can see here, that lesion probably has a safety corridor, and this is what we aimed at. And in the next slide, as you can see here, you can see the corridor that we've established with the laser, and that's 3 months post-op, and her gelastic seizure are now completely resolved. So the literature about LITT has increased significantly, and as you can see over the last few years, so since 2015 now, the number of papers is close to 2,400 only for brain tumor. But it's still a very mixed bag. That group in the Netherlands has made a very towering effort using validated risk of bias and grading of recommendation pod to review the entire literature that was available for LITT over that period of time. And as you can see, out of 835 papers, only 11 were selected, and they represent only 114 patients. And it's still a mixed bag. So when you look at all of this literature, whether it is about defining the patient, the localization of the tumor, and so on and so forth, and most of these reports are in small number, I mean, it's definitely a mixed bag. And it's true not only of description of the patient, but also description of the outcome for these patients. Whether it's overall survival, or progression-free survival. I mean, there's still a very confusing number of these reports that are not really easy to interpret, and that goes also for the type of complication. So I'll just illustrate the largest of these, which is from Mohammadi group at Cleveland Clinic that I think was very illustrative. So what they did was establishing in a large group of patients for newly diagnosed glioblastoma, a group of 24 patients that underwent LITT, and a group of 24 patients out of 171 who underwent a biopsy. And then that group of 24 patient biopsy were matched for age, gender, location, and volume. So as you can see here, I hope that my face is not in the way. The volume of patient for a patient of LITT was 9.3 centimeter cube in comparison with 8.2 for biopsy. The overall survivor was 14 for LITT and 4.2 for biopsy only. And the progression-free survival was a definite advantage again in that group. Fortunately, there's not a lot of elements about KPS, but then they separated that group again in what they call, there's the group of biopsy, but what they call favorable, intermediate, or unfavorable. So the more you burn, basically, which is the favorable group for overall survival and progression-free survival, are the group that have the most benefit. And that other study about recurrent glioblastoma multiforme, which is authored by Munoz and Casabella, where they did a literature search for all of recurrent glioblastoma, you see that 11 studies were identified with 134 patients. Out of these 11 studies, 8 with 107 patients had an overall median survival of 18 months, 6 studies, 93 patients with an overall survival of 10.1, and 8 studies with 119 patients with a progression-free survival of 6 months, which is totally comparable to literature with best treatment available at this time. That large group of pediatric stereotactic laser ablation work group and led by the Medical College of Wisconsin has shown the same thing for a group of pediatric patients, so comparable to available literature in terms of survival. I would say that the caveat of that story was that for these 86 pediatric patients, there was acute complication in 29 time out of 23 patients. So it went from mispositioning of catheter to intracranial hemorrhage, hydrocephalus, and even death. So their conclusion was tumor location, number of laser trajectory, and number of lesion created did not result in a significantly increased risk of complication, which are very high. However, the odds of complication increased by 14% with every centimeter cube increase in the volume of the lesion created. So there's still a lot of question about primary brain tumor, as you can see, and especially for the glioblastoma. And they are still to this day not completely resolved. So the same goes for brain metastasis. So the landscape of brain metastasis has changed dramatically since SRS is now more accessible. Patients are surviving longer. There's more lesions that are being treated, larger lesions also that are treated, and there are retreatment. And as you can see, since 2011, the availability of SRS with the impetus of protecting cognition for a longer period of time has definitely changed the way that those lesions are treated now in the brain. And as a consequence, now we're seeing more and more radiation necrosis. And as you can see in that plot now, because of all of these factors, there are more and more happening. And the treatment of these lesions is not necessarily easy. So the risk factor for radiation necrosis, there's dose and volume, of course, immunotherapy that is becoming more and more prevalent in treatment of cancer patients now, and previous radiation. So you see in that plot clearly that the larger the lesion essentially, and the volume that you have to treat, the more likely you are to develop radiation necrosis. And it's also true for immunotherapy. So if you compare patients that have no immunotherapy and patients that are having immunotherapy, the black and the dotted line here, immunotherapy is more prevalent of a risk for radiation necrosis. So how do you determine, and that's a huge part of the situation also, what is progression of the tumor versus radiation necrosis after radiation therapy? So a lot of people have tried to determine that. In this case that was radiated, you see this lesion happening 6 months after. So the question begged to be answered whether you're dealing with a return of the lesion or radiation necrosis. And a lot of people have put a lot of effort with different success to try to determine strictly by imaging if we can determine whether it's radiation necrosis or it's recurrence. And that potentially can affect, of course, treatment. And more recently, restricted diffusion, as you can see here on that lesion, is a good signal to determine whether there's high biological activity or not. In that case, for example, one would assume that the low biological activity here presume of radiation necrosis. But nonetheless, it's not easy to make that difference. And what are you going to do with these patients? So I like that Wake Forest protocol, which tells that for less than 1 centimeter lesion, you repeat the imaging. For more than 1 centimeter, you need to know what you're dealing with. And the treatment of these diseases is medical efficient in a vast majority. So as you know, steroids and bevacizumab are both non-invasive. They reduce the IC pressure, intracerebral pressure, improve the symptoms. And radiation necrosis may take several months with steroid to improve, while it's going to improve way faster with Avastin. So the risk for steroid hyperglycemia, myopathy, immunosuppression, psychosis, the risk for bevacizumab, intracerebral hemorrhage, thromboembolism, hypertension, and there are some contraindication for bevacizumab as well. So craniotomy, when all hell break loose, basically, all else failed, is the gold standard treatment. There's immediate reduction of intracerebral pressure and mass effect, resection of the acute, if there is intracerebral hemorrhage. You confirm the diagnosis, of course, and it's probably the best option for large tumor accessible or large radiation necrosis that is accessible. It reduces the steroid requirement and survival benefit for patients who failed medical therapy. Now, in that one example that I think is very revealing again, we have a 61-year-old male that has a history of lung carcinoma. He comes to us with a cerebellar and occipital met. The cerebellar met is large and is resected, then he undergoes radiation surgery, then come back with one of these lesions acting out. He is confused, he has memory deficit, and he is aphasic. And as you can see here, we're going to proceed with a biopsy again to confirm diagnosis, and then we're going to start eating that lesion. And despite the fact that it's in a very critical territory, again, close to the edge of the tent, close to cerebrospinal fluid, close to vessel, we feel very confident, and it's quite remarkable with radiation necrosis, the quality of burn that we have there, and it's very fast. The entire procedure normally, once we're connected with the laser in the MRI suite, is about 1.5 hours to 2 hours. For radiation necrosis, it's most of the time less than an hour once we're all connected. So you can see again, I monitor carefully, and the red needle that you see moving is the directionality of the tool. And you can see post-up now what it looks like for the threatened area, and quite remarkable injured area with the blue overline here. And as you can see here, I demonstrate what it looks like in the MRI suite immediately after the procedure. So this is the reason why I feel confident with this MRI on the right to send those patients home the same day. Now, what happened with that lesion after? Let's see what's happening at 2 months. You see it's like still a little bit inflamed, a little bit of swelling, but the consistency has started changing. This is at 6 months, and this is at 16 months. That patient was done in 2017. He's still alive today. Most of his symptoms have resolved. So that's an interesting paper published in 2019 comparing SRS LITT versus surgery. And you can see that both for radiation necrosis and tumor, whether you do craniotomy or you do LITT, I mean, the plot line are very, very similar. So another good paper that was published in 2019 also by the group of Cleveland Clinic with Manmeet Aluwalia, laser ablation after stereotactic radiosurgery, a multi-center prospective study in patients with metastatic brain tumor and radiation necrosis. So you can see that it's very comparable with published literature in that case also. So rapidly, the literature is progressing. That's on 59 patients. The mean LITT volume was 3.4 centimeter, obtaining 84% of local control and 3% of new permanent neurological deficit. So recently, the NCCN, the National Comprehensive Cancer Network, has on these data and review of the data, the panel consensus supported the inclusion of MRI-guided laser interstitial thermal therapy as an option for brain tumor surgery with the following accompanying text. LITT may be considered for patients who are not surgical candidate, craniotomy or resection. Potential indication include relapse, brain metastasis, and radiation necrosis. This is a category 2B recommendation, brain B. So craniotomy versus biopsy, everybody understand that. The invasiveness is very different. The sampling error is non-existent in craniotomy for resection. It exists for stereotactic biopsy. Stereotactic biopsy doesn't affect the mass effect, but the likelihood of going to the NICU is smaller with stereotactic biopsy. It's true also of resection. The length of stay is definitely longer for craniotomy, shorter for stereotactic biopsy. Most patients are discharged home versus rehab, while most of the patients with stereotactic biopsy are discharged home. The wound care and all of the complications associated with the procedure are significant for craniotomy, minimal for stereotactic. Recovery is significant for craniotomy, minimal for stereotactic. Readmission higher for craniotomy. And SRS and chemotherapy have to start a little bit later post craniotomy. So we've combined these techniques now, and as you can see on this patient, 43 years old woman that presented to us with confusion with this butterfly glioblastoma, we decided on two trajectory at the time, even though they were very large lesion. I didn't think about a better solution for her, accounting for how devastating she was already. And so we did the stereotactic implantation, we did the laser treatment, and after that we use exactly the same basically trajectory to go with an endoscope and a suction device to remove whatever was left in that cavity immediately after the procedure. So we put the bolt in, went to the MRI, did the laser treatment, and then resected it. And this is what it looks like immediately during the procedure. It looks like that carbonated, coagulated tissue. As you can see here, after sucking the lesion, a very good outcome without infringing on any of the surrounding territory. And you see what it looks like immediately post-op in comparison with the pre-op. So all of this has been somehow vaporized, and then after that, not leaving any tissue behind and creating too much damage, requiring too much steroids. This is how we proceed. So the question now is, for which lesion should we apply this technology? So everybody is going to recognize after listening to me that those lesions are very difficult to access, whether they're large midline perithalamic lesion, whether they're crossing the midline, whether they're within the ventricle, whether they're multiple, whether they are very focal, or whether they are in very critical area of the brain. So where are we using this technology for? And that's the question that this very selected group that Geisinger joined a few years ago is trying to determine in real life circumstance. So it's a registry. It's called the laser ablation of abnormal neurological tissue using robotic neuroblade, our Lantern project, published, I think it's last year, the first 12-month outcome of that collective of all patients. And as you can see here, there were 223 subjects at 14 different sites. The interim analysis of the ongoing registry, the procedure were performed between 2016 and 2018 with a median follow-up of 223 days. A median age of 54 years old with a median KPS of 90, which is a little bit younger than the population that you see for this tumor, but it's like that group for primary tumor, 59% and 41% for brain metastasis. And as you can see here, a group of pretty significant recurrent metastasis, 38%, and also primary versus recurrent high-grade glioma, 27%. Other primary and new metastasis also, accounting, of course, for a smaller group because those are not the typical patient that are referred for these type of procedure. So like the location throughout the encephalon, from the cerebellum to proximity of midbrain, deep nuclei, thalamus. And so a lot of them were very difficult to access lesion. And in these circumstances, most of the time having more a deleterious effect on the patient. So it's a population that is by definition a little bit more difficult to treat. So the data shows neuroblade procedure have short length of stay, low complication rate, and low 30-day readmission rate. So the average length of stay was 33.4 hours with 4% of adverse event of LITT surgery related, 1.8% of a 30-day or readmission to hospital. So as you can see here, the majority of the patients are going home. So 83% of them have been sent home after the procedure, none to the hospice, and then that rare acute care hospital represented only 2.2%, while all of the others were going either to a rehab facility or a skilled nursing facility. So, and when you look at these patients for the EQ 5D, so mobility, self-care, and usual activity were all improved, and there was no clinical change in pain, discomfort, anxiety, depression, or visual analog scale, and that is constantly acquired in terms of information, the same way as the emotional well-being has demonstrated no clinical changes, social, functional, or total well-being score. So, and that population is surviving very comparably to the general population. You see at 24 months, 12 months is 74.6% for primary tumor and 70% for the metastasis, which is definitely comparable with published literature. So the summary of that list is that it's a prospective study detailing 12 months of outcome of laser ablation for brain tumors. The safety profile of LITT remains consistent with or favorable to previous publications and is similar to the 5-7% complication rate reported for stereotactic biopsy. The length of stay, the readmission rates, and costs were favorable to reported literature for craniotomy. The quality of life results showed better than expected outcomes in a population of patients who had mostly recurrent disease and a short life expectancy, and the overall survival was better than expected for a real-world registry and comparative to published literature. So all of this has brought Eric Leuthard is a master in the domain, has been a trailblazer. You all probably know about Ganesh, who is in the Methodist now in Houston, and Jean Barnett, who is leading the effort of oncology at Cleveland Clinic. That AANS and PNS position statement on MRI-guided laser therapy. And LITT is an appealing treatment option. There's one that is unmuted now. Okay, LITT is an appealing treatment option because it offers a method of minimally invasive targeted thermal ablation of a lesion with minimal damage to healthy tissue. There's a growing body of evidence to demonstrate that LITT is an effective and well-tolerated cytoreductive option for treatment of neoglioblastoma, recurrent glioblastoma, METs, and recurrent metastasis. Intracranial LITT is also an effective option for addressing radiation necrosis with an overall reduction in steroid dependence for these patients, especially in instances where the therapeutic window is narrowed such that craniotomy is not a viable option. LITT can play an important role in treatment of for glioma or metastatic brain cancer. A multidisciplinary approach remains the cornerstone in the treatment of patients with brain tumor or radiation necrosis. It's important that physicians have discretion to exercise their clinical judgment when evaluating the most appropriate option for their patient individual treatment. That's the conclusion of that position statement. And the field is expanding very rapidly. I'm almost done. Now we have very good fiber tracking, matching while we're doing the procedure. And one can easily imagine that eventually, I mean, all of MRI imaging is essentially interpretation of water in the brain. Let's think that radionomics are going to tell us exactly what kind of heat tolerance a tissue might have. And then we can even better plan how we're going to interact with that tissue during the procedure. And some very meaningful effort are made in that trajectory right now, and they are all in development. So extracting all of the data of all of the cases that we've been doing and trying to establish what is the ideal profile for thermal ablation. Eric Leuthard's group has also done a towering effort in my mind to demonstrate that we can, with LITT, open the blood-brain barrier better than with any other type of medium, As you can see here in that effort, and its blood-brain barrier disruption is induced by LITT, and it's measured by biomarker, but for almost like 30 days, the blood-brain barrier is open. And that was confirmed also by DCE, which is essentially a dynamic contrast enhanced MRI that assessed in vivo drug effects on vasculature. And again, 30 days of that blood-brain barrier opening in the same group, as then applied that to the lab. And what they demonstrated with that animal model is that laser therapy increased the blood-brain barrier and blood tumor barrier permeability by disrupting endothelial cell tight junction. And in a preclinical mouse model, laser ablation with adjuvant chemotherapy significantly improve animal survival. So if we eventually, hopefully, find the right chemotherapy, delivering this through the opening of the blood-brain barrier, that is essentially a lot of the approach with ultrasound lesion and other medium to open the blood-brain barrier is immensely appealing. So I would just finish by some words of caution. I think what is critical is that LITT is intended for ablating intracranial soft tissue, including brain structure. Patient must be able to undergo, of course, MRI exposure and be surgical candidate. The technology is not appropriate for every lesion and location. It may be difficult to use the technology on certain large or irregularly shaped lesion. Possible adverse events include compromised device function, hematoma, embolic events, so not dissimilar to the complication that you would have with craniotomy, edema, bleeding, unintended major tissue damage, and permanent neurological deficit. So prior to using these devices, one has to review the instruction for use, of course, and a complete listing of indication, contraindication, warning, precaution, and potential adverse events. I have always liked this saying that a fool with a tool is still a fool. On this, I want to thank first all of our partner at Geisinger that are making this extraordinary journey possible. And I'm thinking especially about Natasha Gatson, Manjari Pandey, our oncologist, my superb partner, Anand Mahadevan in stereotactic radiosurgery. Their open-mindedness is allowing us to explore this possibility of treatment for every patient that we review on our tumor board. I want to mention, of course, Gino Mangezulo, who is our radiologist, neuroradiologist extraordinaire, as well as Syed Kazmi, our pathologist, our research assistant, Chelsea Deer, and also Angie Whitmire, my personal assistant, Heather Paddock, all of our resident fellows, technical support, non-clinical staff that make this endeavor a pleasure to go through. So on this, I want to thank you also for your attention, and I would be happy to entertain any question.
Dr. Lacroix, thank you very much. That was a great talk, and thank you for all the work you're doing. Because I think everybody would agree that the diagnosis of brain tumor, especially glioblastoma, is still such a devastating diagnosis that, every time hearing that, even the, certain steps are done, to prolong the survival and quality of life, it's fantastic. We do have several questions for you. Will there be a day when all tumor surgery will be minimally invasive?
I believe that. I mean, I have started migrating into that domain a long time ago now. I mean, we're doing this, and it's because of a combination of all of these technology, basically, whether it's now 5-ALA, whether it's ultrasound, whether it's minimal invasive approach, all of these basically technology that allow us to identify a very small corridor to reach these lesions. And we do that with open craniotomy. And minimally invasive is true, but for me, it's minimal access. So for all of these corridors in the brain that we can identify where we can safely introduce ourselves to go and do the work that we have to do without distorting the surrounding brain is definitely the way to go.
Do the genetics of the tumor affect the influence the thought behind open versus minimally invasive procedure?
The diagnosis will definitely influence. I think that you've seen that also versus high-grade glioma and low-grade glioma. I think that right now, most of our expertise is on high-grade glioma. I think that there's more to come about lower grades. So of course, the genetic makeover of these tumor as we're looking at the new World Health Organization with IDH mutation being cornerstone in making these decisions, of course, it's going to have an impact. And that's part of the journey in my mind of personalizing treatment for these patients. It's not only chemotherapy, but it's also procedural.
What will make you choose LITT versus radiosurgery for small, such as, for example, 2.5 centimeters deep lesion?
So, I mean, in our group right now, our think tank is definitely to look at every patient and ask ourselves the question, is it a good candidate for LITT, accounting for the indication that we've recognized, okay? Then I can tell you that very superficial lesion, I don't know if I'm adding that much of a benefit if it's in non-eloquent territory, but if it's in eloquent territory, then we're gonna reconsider. So the way that I see LITT right now is for all of these lesions on patient that would be taxed, for example, by an open procedure, that we could probably do this with the fail-safe that surgery is not gonna be impossible in the rare case of failure. So far with our treatment, there's not that many people that we had to revisit. We had to evacuate some of these larger tumor initially through these minimally invasive approach, like the one I illustrate with the endoscope and the suction device. But essentially, I'd say that it's the collective and the experience of that collective that matters most at this point, because as I showed you, I mean, it's all over the place.
Now, after LITT, do patients still undergo standard oncologic adjuvant therapy?
Absolutely. It's the approach, the surgical approach is different, and the rest of the procedural. So actually, we can get them to radiation therapy and adjuvant chemotherapy faster.
What is the risk of bleeding from LITT?
So far, I can tell you, you've seen the complication that have been reported in the literature, comparable to any biopsy, so less than 3%.
Okay. And this question is more for your, overall your thoughts about training. As we get more and more engaged in minimally invasive surgery, what are your thoughts for trainees getting adequate experience for open surgery, for all neurosurgery training from oncology to vascular?
I think it's critical to select I mean, I would say like the environment where people are prone to these approach, and Geisinger is one of them. Unwarranted kind of ask for any resident that might be interested in those minimally invasive procedure, come here, we do a lot of them. I'd say that you need to have people that are not using these tools by bravura, but are very cautious. And I think that if you're trained in an environment where it's part of a armamentarium, but you cannot afford not to do what you're expecting and doing and not doing it safely, because you're using a different approach that is more minimally invasive. So again, minimally invasive for me is target specific surgery. I think that the fundamental is that by disrupting less of the surrounding tissue, we're getting better outcome.
Well, Dr. Lacroix, thank you very much again for this great talk. I'm getting all these comments, how great the talk was and time appropriate. And then hopefully we'll see you sometime in the
hope
future.
So, Peter. There was a pleasure. Thank you very much for hosting that. Thank you, Atom, again. I think I mean, we're spending part of the weekend together. And I'm very happy with the invitation. And please, I don't know if Errol is on board, but thank him also for the kind invitation. And thank you, everyone, for your question and listening.
Absolutely. And for everybody who joined, I would like to wish happy holidays. And then we'll meet again in 2022. Have a good one.
Fantastic. You too.